Hello everyone, this is Cody Porter with Clinical Education. I'm here today to discuss a new protocol, trauma arrest protocol. So let's get into it. So first, let's take a quick look at what we'll be covering in this session. We're going to start by looking at how cardiac arrest management has evolved over time, especially when it comes to trauma. There's a big difference between the evidence we have for medical versus traumatic arrest, and we'll explore what the latest data is telling us about best practices in trauma care. Next, we'll walk through the traumatic arrest protocol. We'll break it down step by step so you can see how it's structured, what each part is designed to do, and how it applies in real clinical situations. We'll also talk about the MARCH algorithm. You've probably used it before: massive hemorrhage, airway, respiration, circulation, and head injury hypothermia. We'll connect each of those steps to the trauma arrest protocol so you can see how they work together in the field. Then we'll dive into some real-world scenarios. We'll look at two scene calls. One where Magic Valley paramedics arrives first without critical care, and another where critical care arrives at the same time. These examples will help us understand how team dynamics and decision-making shift depending on who's on scene and when. And finally, we'll wrap up with some special considerations. Things like patient age, injury mechanism, the environment, and available resources can all impact how we manage traumatic arrest. We'll talk through these factors to help you make informed decisions in complex situations. Let's take a moment to look at the current data surrounding out-of-hospital cardiac arrest. According to CARES data from 2020, the majority of adult cardiac arrests, nearly 74%, occur at home, with public settings and nursing homes making up the rest. Now, in about half these cases, the collapse is not witnessed. Now, when it is, it's most often by a layperson or a 911 responder. Survival rates remain low. Only about 9% of patients treated by EMS survive to hospital discharge, and just 7% do so with good functional outcomes. However, survival rates improve significantly when certain factors are present, such as bystander CPR, EMS witnessed arrest, or initial shockable rhythms, like ventricular fibrillation. For example, survival can reach up to 23% in patients found in VF-VT. Now, despite these improvements, the overall survival rate for out-of-hospital cardiac arrest has remained relatively unchanged over the past 3 decades, hovering around 7%. International data supports the importance of early intervention. A Swedish study analyzing over 30,000 out-of-hospital arrest cases found that patients who received CPR before EMS arrival had more than double the 30-day survival rate compared to those who didn't. So what's the takeaway? Early recognition, rapid response, and bystander CPR are critical. Now, while we've made progress, there's still a long way to go in improving outcomes for cardiac arrest patients. Now, while medical cardiac arrest have been extensively studied and guided by decades of data, traumatic cardiac arrest, or trauma out-of-hospital circulatory arrest, remains a more emerging and evolving field. Recognizing this gap, leading organizations, including the National Association of EMS Physicians and the American College of Surgeons Committee on Trauma and the American College of Emergency Physicians, have issued a joint position statement. They emphasize the urgent need for evidence-based, pragmatic, and collaborative protocols to improve outcomes and ensure clinical safety in these high-risk scenarios. Now, the cornerstone of managing traumatic arrest is the rapid identification and treatment of reversible causes. Unlike medical arrest, where chest compressions and epinephrine are often frontline interventions, trauma arrest demands a different approach, one that will prioritize life-saving interventions within the EMS scope of practice. Now, these life-saving interventions include external hemorrhage control using direct pressure, wound packing, or tourniquets, airway management using the least invasive method necessary to maintain oxygenation and ventilation, chest decompression when there is clinical concern for a tension pneumothorax. Chest compressions may be considered, but only after other life-saving interventions have been addressed. Epinephrine should not be routinely used in traumatic arrest, and if it is used, it should never precede other critical interventions. This evolving guidance reflects a shift in how we approach trauma arrest, moving away from a one-size-fits-all model and toward targeted, reversible, cause-driven care. As more data emerges, our protocols will continue to evolve, and staying current is essential for delivering the best possible outcomes. When it comes to managing traumatic injuries, especially in high-stakes environments like combat or pre-hospital trauma scenes, the MARCH algorithm has become the gold standard. Originally developed by the military, MARCH stands for massive hemorrhage, airway, respirations, circulation, and head injury hypothermia. It was designed to prioritize the most immediate, reversible causes of death in trauma patients, especially in austere or resource-limited settings. Now, over time, MARCH has been widely adopted in civilian trauma care because of its clear, structured approach. It helps providers stay focused, make rapid decisions, and deliver life-saving interventions in the right order. In this training, we'll break down each step of the MARCH algorithm and how it directly connects with our trauma arrest protocol. When we talk about traumatic cardiac arrest, the first priority in the MARCH algorithm is massive hemorrhage, and for good reason. In trauma, uncontrolled bleeding is one of the most immediate and reversible causes of death. Now, in medical calls, we follow an ABC sequence: airway, breathing, circulation. But in trauma, the approach isn't always so clear-cut. A recent review looked at how the CAB approach compares to the traditional ABC sequence in adult trauma patients. What they found is important for how we prioritize care in the field. In hypotensive trauma patients, especially those actively bleeding, early airway management, like intubation, before addressing circulation, was associated with significantly higher mortality. In fact, patients who were intubated before receiving blood products had worse outcomes, including a higher risk of post-intubation hypotension, which itself was linked to increased mortality. This supports the idea that in trauma, circulation must come first, especially when hemorrhage is the primary issue. That means our first actions should focus on controlling external bleeding using direct pressure, wound packing, tourniquets, or pelvic binders. Only once bleeding is controlled and perfusion is addressed should we move on to airway and breathing. That said, there are exceptions. If a patient has a critical airway injury or severe hypoxia, airway management may still take priority. But for most trauma arrests, managing hemorrhage early could be the difference between life and death. This is why the M in MARCH is so critical, and why our protocols reflect the unique physiology of trauma and don't just follow the patterns of a medical arrest. Next in the MARCH algorithm is airway. But it's important to remember that in trauma, securing the airway should never delay more urgent life-saving interventions. The goal here is simple: maintain a patent airway using the least invasive method necessary. That could mean a jaw thrust in a nasopharyngeal airway, or even basic positioning. Remember, resource allocation is imperative, and if there is only one advanced provider on scene, a bystander jaw thrust could make do until resources can be reallocated to properly address the airway. Advanced airway management, like intubation, should only be performed if absolutely necessary, and only when it won't distract from treating more immediate threats like massive hemorrhage or tension pneumothorax. In trauma, time is critical, so when it comes to the airway, keep it simple, keep it fast, and keep it focused on what the patient actually needs. Now let's talk about the R in MARCH, respirations. In trauma, respiratory compromise is often caused by tension pneumothorax, which can rapidly lead to cardiac arrest if not addressed. That's why this step focuses on identifying and relieving life-threatening chest injuries. For paramedics, this means being prepared to perform needle thoracentesis when there's clinical concern for a tension pneumothorax, especially in the setting of a traumatic arrest. While current guidelines don't recommend prophylactic bilateral decompression in the absence of a chest trauma, I personally advocate for a pretty low threshold in these cases. If the patient's in traumatic arrest and chest trauma is even suspected, decompression may be life-saving. For critical care providers, the next level of intervention is tube thoracostomy. This provides a more definitive solution for relieving pressure and re-expanding the lungs, especially in prolonged transport or when needle decompression is ineffective. The key takeaway here, don't delay. If you suspect a tension pneumothorax, act quickly. Respiratory compromise and trauma is often reversible, but only if we intervene early and decisively. Next in the March algorithm is circulation. And in trauma, that means recognizing and treating shock from blood loss as early as possible. It all starts with vascular access. Large bore IVs are ideal for resuscitation, but IO access is absolutely acceptable and far better than delaying care. Don't spend too much time hunting for the perfect vein. In trauma, time is blood loss, and we should maintain a low threshold for going IO when access is difficult. If you haven't picked up on it yet, time is a critical factor in trauma care. Early intervention saves lives, and circulation, no exception. For our critical care teams, this is where carrying whole blood becomes a game changer. A recent study published in JAMA Surgery looked over 1,300 trauma patients who required massive transfusion. The findings were clear. The earlier the whole blood was given, the better the survival outcomes, not just at 24 hours, but even 30 days later. In fact, the survival benefit was seen as early as 1 hour after arrival. Patients who received whole blood sooner had a significantly lower risk of death, with adjusted hazard ratios showing up to a 60 to 70% reduction in mortality. This reinforces what we already know. Time is blood. In traumatic arrest, if we wait too long to restore circulating volume, we lose our window to reverse shock and save the patient. So when it comes to circulation, especially in the setting of trauma and arrest, early blood is critical. For paramedics, this means establishing access and early request for air ambulance support. And for our critical care teams, it means initiating transfusion as soon as possible, because every minute counts. The final step in the March algorithm is H, which stands for head injury and hypothermia. While head injuries are important to recognize, in the context of traumatic cardiac arrest, hypothermia is the more critical concern. Hypothermia doesn't just mean the patient's cold, it's a key player in the trauma triad of death, alongside acidosis and coagulopathy. These three factors feed into each other, creating a vicious cycle that dramatically reduces the chances of survival. Here's why hypothermia matters. As body temperature drops, coagulation slows down. The chemical reactions that allow blood to clot are temperature dependent, and colder temperatures impair both the humoral coagulation cascade and platelet function. This leads to continued bleeding, worsening shock, and further temperature loss. What's more, most lab tests for coagulation are performed at normal body temperature, so they may not even reflect the true severity of coagulopathy in a hypothermic trauma patient. In trauma arrest, preventing and treating hypothermia is essential. That means minimizing exposure, using active warming techniques, and recognizing that even mild hypothermia can have serious consequences. So as we wrap up the March algorithm, remember, hypothermia kills silently. Address it early, aggressively, and consistently, because it's one of the few things we can control in the chaos of trauma.